Okay, hopefully everyone's heart rates have come down after last night. Holy smokes. Okay, so good morning, everybody. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So really excited about today's topic and speaker. As much television as we've been watching, Oilers fans, in between, we see a lot of commercials that leave one a little bit nervous. And so I think this topic was very timely. I'm delighted to introduce Dr. Peter Senior, who really needs no introduction, but as you know, he's the director of the Alberta Diabetes Institute and the Charles Allard Chair in Diabetes Research and Professor of Medicine at the university in our department. His clinical appointments as the medical director of the clinical islet transplant program, and he's a staff endocrinologist for Alberta Health Services in the Edmonton zone. He completed his specialist training in diabetes and endocrinology at the University of Newcastle upon Tyne. Newcastle upon Tyne, got it, in the UK, where he received his PhD in 2002. His clinical and research interests focus on type 1 diabetes, hypoglycemia, diabetic kidney disease, and islet transplantation. He's published approximately 200 scientific articles. He received the Gerald Wong Service Award from Diabetes Canada in 2020 for diabetes research, clinical care, the organization, and diabetes advocacy. And he recently completed 2 terms on Diabetes Canada's board of directors, including 3 years as board chair. He previously served as chair of the Diabetes Canada's Clinical Practice Guidelines Steering Committee and its professional section. And he continues as medical director of the Alberta DCAMP for children with type 1 diabetes. And he is an outstanding speaker. So I'm really excited to hear about his rounds. And I will give it over to him to ask your doctor.
Thank you, Norma. Felt exhausted listening to that. I think my mum wrote it. She's very proud. So thank you for that. Just a few disclosures. So again, I have industry relationships with a number of companies who do all sorts of things. I think most relevant here are Novo Nordisk, who makes semaglutide or Ozempic, and Eli Lilly. We've done some kind of preliminary trials with them with a dual agonist, which is not yet on the market. So what I'm going to try to do today is think a little bit about our biases and how they impact things. And I think weighing evidence is always tricky. You know, how do we weigh grains of sand against grains of lead? And again, it depends on how many there are. And then think a little bit about practically about what that's actually going to mean for us in our day-to-day practice. You know, we see patients coming in with all sorts of diseases, and probably 25% of people in the hospital have diabetes. So many of them will be on these medicines or maybe asking about them. So I'm going to use GLP-1s probably as my shorthand for GLP-1 receptor agonists and also dual agonists that may interact with glucagon like peptide 1 and GIP, or maybe with glucagon, and then there are triagonists as well, but I'm going to lump them all together. And this is where you get the chance to be involved and interactive. We'll take a sort of show of hands in the room, but we will have people online answer the questions as well. So have you been asked about taking Ozempic by a friend, a relative, or a colleague? So hands up for yes. And again, that's most people, so maybe a few haven't. And let's just see what the online community feel. 86% yes, 40% no. So this is in the zeitgeist, that is for sure. So too many buttons to click. So the next question is this one. What was your response to that question? Was it, again, we'll maybe take it in order, but highly favorable, somewhat favorable, neutral, somewhat negative? okay, you're all on my side in the room at least. What about strongly negative? Because certainly you read a lot of stuff online that says, don't take this because you will get X, Y, or Z. And we'll share the results with the online people. So 55% somewhat favorable. So I think we're sort of leaning slightly towards this seems to be a good thing. Now, there are a couple of more questions, so don't go to sleep quite yet. Are the patients that you see in your clinical practice or in the clinics that you're doing, are they taking GLP-1s? Again, yes, more and more. Yes, a few. No. Anybody not seeing patients taking these? Don't know. Again, that I'm not sure why that option's in. Actually, a few people online don't know. But essentially 70% are saying yes, more and more. So this is a common drug that's being used widely, and it probably is helpful if we know a little bit about that. So here's a different question. Have you ever written a prescription for a GLP-1? And this is number 3, I think. Is that right? 4. Thank you. So hands up for yes, I've written a prescription for a GLP-1. I think I'll put my hand up for that. No. So yeah, I guess that's true. Again, that may just not be the circumstance that fits. And I think online we've got about 40% yes, 30% no, and 26 not applicable. Maybe they're not prescribers. Okay, and then I think this is our last question. And this is thinking away from GLP-1s. The question is more about new therapies that come. You see the headline, you click the link, you get to an article that's behind a paywall usually. This is a miracle cure, or else it's in mice. And again, how skeptical are you about new therapies? Are you very skeptical about all new therapies? Are you more skeptical about therapies that you don't use or don't know that much about? I think that's probably where I put my hand up. Somewhat skeptical unless there's hard endpoints. Again, if you're sort of saying, if there's no hard endpoint, I don't care that the CRP is down by 12%. And then you just kind of like, well, if it's an important topic like obesity, diabetes, they're big, I'm just going to use whatever is new because it's such a big problem. And I think the poll online is saying that about 62% are somewhat skeptical unless there's hard endpoints. And I think that's okay. All right. So let me go back. And again, because I'm old, I'll talk about history. And unfortunately, I'll be able to say, and I was there. So incretin hormones are kind of this broad class, and they are gut-derived peptide hormones. One of the first ones that discovered was called GIP, and it was gastric inhibitory peptide because they extracted it from gastric juice, and if they infused it, it slowed down gastric emptying. And isn't that interesting? Fortunately, it's a bit like naming trials. Those initials, GIP, also were used for the peptide's other name, which was glucose-dependent insulinotropic peptide, which essentially meant that this is a peptide that stimulated insulin secretion, but only when blood glucose was high. So intriguing that this was affecting gastric emptying and endocrine function in one peptide. And so this group of hormones seem to link the brain, the gut, and the pancreas. The gene from which these peptides are derived is called the proglucagon gene, and it can be cleaved and sliced up into different chunks. And glucagon is what is made in the pancreas and alpha cells, and that's because of the action of proconvertase 2. Prohormone convertase 1 and 3, which tend to be more in the gut and the brain, they will slice up the gene differently, and you get GLP-1 from L cells in the intestine. You can get GLP-2, which is used therapeutically for short gut syndrome. And then you can get these other fragments as well. But essentially, the things which are most relevant to diabetes are glucagon and then the GLP-1. If you eat a meal your blood sugar will rise and then will fall because of the insulin that's being produced. If you give the same load of glucose intravenously, the blood sugar goes much, much higher, and the amount of insulin that's released is much less, and it takes longer to bring it down. And so there's a difference between whether the food is, or the nutrients are delivered via the gut than via the intestine. And the difference is that food delivered to the gut triggers the release of these GLP-1 and incretin-like hormones, and they sort of augment the insulin production. So insulin secretion is sort of more complicated than just, glucose being driven. And so this gap shown by the pink arrow is just showing that difference in insulin release when food is delivered via the gut, and that indicates the impact of incretin hormones. And strikingly, healthy controls compared with people with type 2 diabetes. In type 2 diabetes, that incretin effect is blunted. Now, do they not make enough incretins? Are the incretins not active quite enough? That's still under active debate. And I think this would be my quick summary slide of where these drugs work. So again, initially it was very much, they stimulate insulin when you need it. That's good. That will help your diabetes. They suppress glucagon at the same time. Glucagon tends to make us insulin resistant. So again, we're doing two things which will help glucose control. And the weight loss was a lot about, well, why is that? And it seems actually to be that that's really driven by the brain. And so feeding centers, hunger centers, satiety centers in the brain, again, there are GLP-1 receptors there, and that's where the drugs are acting. The delayed gastric emptying could be the blessing and the curse. So again, that will contribute to many of the GI side effects, which I think are well known, but it also probably slows delivery of nutrients into the gut so that the absorption of sugar is slower, and so the body has more time to actually process that, and we avoid some of the postprandial excursions in glucose. So again, if you want some boring science to annoy your neighbors with at the next time you're at a barbecue, pay attention now. So this is the kind of the amino acid structure of human GLP-1, and it is cleaved very rapidly by peptidases. This is DPP4, so an endopeptidase that's sort of in the bloodstream all the time. And so human GLP-1 has a half-life measured in minutes. You trim off these last two peptides, and the fragment is then inactive. If you look at human GIP, again, the same AE residues, DPP4 slices those as well. And so these DPP4 enzymes, they've been targeted by drugs like sitagliptin and saxagliptin and linagliptin to slow down and enhance the action of native incretin hormones. But there was a discovery that the Gila monster, so this is a lizard, this photograph was taken in the zoo in Scottsdale by an old camera phone, as you can probably tell. But the saliva of those lizards contains exendin-4, and exendin-4 looks very, very like human GLP-1. But you don't have this AE residue together. You've got a different set of residues. And so exendin-4 is not broken down by DPP4. And so it has a much, much longer duration of action. And so this gave us a clue as to how we could design GLP-1s that would be suitable for being given twice a day initially, then once a day, now once a week. Now, you might think, well, these are new drugs. We don't know very much about them. But the reality is that they have been around a long time. And as I was preparing this talk, I realized that I gave a talk at the Internal Medicine Update in 2009, talking about new therapeutics in diabetes. And we were talking about incretin hormones in 2009. So that's quite a long time ago. But this is the sort of timeline for approval of GLP-1 receptor agonist medicines in Canada, going back to 2010. And the ones in blue are the trade names of the ones that have been licensed for obesity. The others are the trade names licensed for diabetes. So I've told you this already, but just a little bit of reminder for sort of therapeutic medicines that we're using in clinic. So they're resistant to DP4. That's kind of why they work, as long as they do. They're not metabolized in the liver. They're not renally excreted. They're denatured sort of in the body, in the blood by peptidases. It may not be DPP4. It may take a bit longer, but that's the main mechanism of metabolism. They're not nephrotoxic. That's an email that I've had sent to me by some nephrologists at times, albeit a few years ago. They don't cause hypoglycemia on their own. Okay, so it's not a sulfonylurea, it's not insulin. And again, the most common adverse events are GI side effects, and we can talk about that if we need to. So let's think about, evidence and how we make decisions. And I think there's probably two broad strands. So we've got randomized controlled trials. And randomized controlled trials of new medicines are, whether we like it or not, designed to achieve licensure. Okay, so you take a high-risk population, you choose your endpoint, you give the medicine versus placebo, you count the bodies at the end, and if you've got fewer bodies in one pile than the other, great, you're off the races. And they do generate high-quality evidence that will tell you about efficacy, and you've accounted by randomization for all those other chance variables. But they're relatively short term. So if you want long-term data, you're never going to get them in a pharma trial because they can't afford to do them long enough. And indeed, in your career, you may not be able to wait long enough for that long-term data. You then have questions about generalizability, because if it's been tested in younger, high-risk patients, well, what does that mean for people with comorbidity, which is all of the people that we see? And they're good at proving benefits, but they're not good at detecting rare harms. Big harms they'll detect, but rare harms they won't pick up. And so observational data, again, can fill in the gaps, and they're actually better at picking up rare harms, but they can only identify associations. And again, we're going to be quick to teach our residents, association is not causation, until it's something that we believe in or we're suspicious about. And then all of a sudden the associations become much more important for us. And again, I've been very, very cynical in terms of the reasons that people do publications based on observational data, because sometimes I wonder if it's like, it's a quick paper, it gets a headline, but actually whether it's actually clinically useful is a big, big issue, because you then have all the unpacking to do with the patient saying, I stopped my drug because I saw this headline in the newspaper. So what are the benefits of GLP-1s? And again, I think it's important that we kind of cover these briefly. I really want to talk maybe more about the harms and whether they're true and how we weigh them. But again, just to recapitulate. So this is from a review by Dan Drucker from Toronto, who, again, a very preeminent GLP-1 receptor or GLP-1 scientist. So these drugs were developed for type 2 diabetes. They clearly are effective for treating diabetes. They're clearly very, very effective for treating obesity. And as we've done those studies, we've seen that there's really very striking cardiovascular benefits. So major adverse cardiovascular events, admissions for heart failure, diabetic kidney disease, cardiovascular death in a really broad range of people. And again, so if you want hard endpoints, I'm not sure that I know many classes of drugs that have got more sort of mortality data than these ones. Again, if you look at diabetic kidney disease, heart disease, and possibly stroke, again, some of the stroke data is really derived from meta-analyses rather than direct clinical trials with that as a primary endpoint. But then we've also got these emerging hints and the ongoing clinical trials in metabolic associated liver disease. So what used to be called NASH and then MASH and now MASLD. And I think all is actually due to insulin resistance, interest in Parkinson's disease, interest in Alzheimer's disease. And actually there's some endpoint data showing improved function in people with peripheral vascular disease with and without diabetes. And again, the highlights here, I've listed the names of the trials. Again, if you want to review these afterwards, you can do that, but I'm not going to hit you over the head with that. But again, I think even the cardiologists are beginning to think this might be important because it helps with heart failure. So this is the list of the kind of the main outcome trials. The orange trials are ones done in overweight, obesity, non-diabetes populations. The rest are in diabetes. And again, just really, really consistent data. Just to highlight that SURMOUNT of tirzepatide, at the moment, they're just showing benefits for weight loss and and glycemia. Their CV outcome trials are yet to be published, but they are in process. So just as a way of context, in diabetes, we talk about the ABCDs, so it's A1C, it's blood pressure, it's cholesterol management, cardiovascular risk. And statins are just part of everyday practice. And again, the data there is you get a 20 to 25% reduction in hard endpoints for every 1 millimole reduction in LDL. And, more effective in people with diabetes because they're a high-risk population to begin with. And so they've been proven in both primary and secondary prevention cohorts, and we now consider them standard of care. We think about ACE inhibitors. Again, Canada's the home of the HOPE study, which really established ramipril as being a key drug to have an impact for cardiovascular endpoints in people at high risk, many of whom had diabetes. But again, also very well established for heart failure, for stroke, for kidney disease as well. So again, if we had a patient who was not on a statin, not on an ACE inhibitor, we would be saying, well, they're not getting guideline-directed care. We'd try and make somebody feel guilty about that. These were the foundations on which the trials of GLP-1 receptor agonists were performed. People had to be on best medical therapy to begin with. And yet, despite that, we're then seeing a sort of 14% reduction in MACE, similar reductions in mortality, be it cardiovascular or all-cause, as well as this weight loss and blood pressure reduction. So again, if you want hard endpoints, they're there. If you want sort of patient-important outcomes, which might be glycemia and weight, they're sort of there as well. And again, I think the data is robust. It's of a magnitude similar to current best therapies. And if you think about numbers needed to treat for statins, and I'll focus maybe let's focus on mortality. Number needed to treat 83. That's not a tiny number, but mortality, that's an important event. If we look at GLP-1 receptor agonists, again, if you've got very high-risk population with cardiovascular disease and chronic kidney disease, you've got a number needed to treat of 42 over 5 years. So again, these are not kind of sprinkles on the top of therapy, they're the cake, which may not be the best analogy. So what about the harms? So this is, again, stolen shamelessly from Dan Drucker. So this was a review he published last year. And so the key thing here is just to make sure that you pay attention to the shading in the background. So the gray shading background here on the left, these are adverse events of these drugs. So nausea, diarrhea, constipation, vomiting. Those are clearly related to the drug. It is striking that people can get diarrhea and others will get constipation. Generally, these drugs slow things down, so probably constipation is more common, but there's not a small cohort that get diarrhea as their main GI side effect. Questions about ILIS, gastric contents being retained. So when you're doing your endoscopy, you say, oh, there's still stomach contents here. I can't examine that very well. Gallbladder is a disease for sure. We see the same with rapid weight loss after bariatric surgery. We see an increase there. There is this question about acute kidney injury. Again, there's other data which says that maybe not be true. And I think some of the descriptions were if people got very, very nauseated, were vomiting, they got dehydrated, there were more cases of acute kidney injury in some trials. The blue ones are possible adverse events. Again, we might ask questions about the neuropsychiatric effects. There were some questions about suicide risk. That was actually proven not to be the case in more detailed analysis of large data sets from both Europe and North America. Sarcopenia is one of the latest bits of mud that people are throwing. If you lose a lot of weight, you lose fat and you lose muscle. That's kind of the way it goes. If you spend more money, your bank balance goes down. That's sort of just a fact. And then these other questions, retinopathy, thyroid cancer, pancreatic cancer, these are down called doubtful AEs, and I think that is certainly true. And I'll show you a bit more data about that. So this was published, it was accepted, I think, just before Christmas, published just in January of this year. And again, a complicated analysis that, to be honest, I don't really fully understand, but it impressed me. It blinded me with science. And what they did was they took sort of administrative data from the US, just gazillion people, well, not a gazillion, but I think more than 1 million people were in the study. And essentially they looked at people who started GLP-1s, people who started other drugs for their diabetes, people who stayed on existing drugs, and then they could do comparisons between people who started, GLP-1, how did they do compared to someone who started an SGLT2 or a metformin, and how did that compare with usual care? And essentially we've got this database. There was 200,000 who started GLP-1s, you had 160,000 with SUs, 120 with DPP-4s, 260,000 with SGLT2s, versus a control group of over 1 million who just continued using regular diabetes drugs, none of these new fancy ones. And they've, again, meta-analyzed all these data, and this is the list of the adverse effects that they identified that were statistically significant. You can see that the hazard ratios of the ones that were statistically significant are between sort of 1.05 and maybe 1.3, so 5 to 30% increase. And again, they're listed in, by class of agent. And again, a lot of the things that we might expect. So GI side effects, more kidney stones and interstitial nephritis, various bone pains and joint pains and things like this. Again, I'll just remind you that this is observational data. And again, this is a little bit extrapolation, but potentially you could imagine the situation that somebody's on one of these medicines, they've lost a lot of weight, they then start doing things that they may not have been able to do, and they say, hey, my arthritis is bad now. Or maybe they're now fit for the knee replacement when previously they were told, no, you can't have it because you're overweight. So sleep disturbances and headaches, again, more commonly reported, and then these symptoms, nausea and vomiting, abdominal pain, syncope. And again, is it medicine on its own? Is it the medicine in somebody who's lost weight, whose blood pressure is better, and they may not need quite so many blood pressure meds? And then this is the kind of the little graphic for that. And again, I'll not repeat myself. So pancreatitis has been a really common one, and it is a challenge, and it's quite a common question. Somebody's admitted with pancreatitis, they've just come out of the ICU. Should they ever start this drug again, or should we put them on 4 shots of insulin per day? And the trial data is really, really strong. Many of the trials of these medicines measured amylase during the study. And amylase tends to go up a little bit in the study, but well within the normal range. If you count the cases of pancreatitis, the cases are lower in the active treatment than in the placebo arm. Because if you've got type 2 diabetes, obesity, and your A1C is 11%, you're at higher risk for obesity. So it's very difficult to unpick this. But the CVO2s, the meta-analyses don't suggest any increase. I think there is some speculation that, again, could this be an indirect effect? Weight loss, gallbladder disease, is that going to trigger it? And then there'll be people who just have pancreatitis and are on a GLP-1, and it's an overlapping coincidence. And certainly the adverse reporting databases, which again are biased to report things that happen with new drugs, that's really been a place where it's raised the question mark. But again, the detailed analysis has not really convincingly shown this. And I think my approach is to take a kind of patient-centered approach and sort of say, look, this is what I know from the data. This is what you've experienced in the ICU for the last few days. You know what your diabetes was like before, and try to weigh that up. And I think taking a gentle therapeutic trial approach and saying, well, look, let's try you back on this. Let's see what happens. If somebody's had, a gallstone, they've got a clear cause, that's now been treated, I worry much less. So these are the beneficial effects. And again, probably the main thing to say is that there's a lot of these, and the print is small, and you probably can't read them all. And again, hazard ratios on the same kind of scale as before. And I've summarized them here. I think this is maybe a little bit easier. So that the top row are the ones you know about. We've seen that from clinical trials. But this kind of, again, observational data, reduced risk of neurocognitive disorders, reduced risk for psychotic disorders, better substance use issues, reduced risk of seizures. I'm not sure if I can explain that. And then we've got these other ones like less infectious disease, less thrombotic disease, and less severe respiratory infection. So again, yes, there's some bad, and yes, there's some good. And again, unexpected things maybe on both sides in this observational data. So why all the fuss? What you see is the red wine stain. You don't see the beautiful white tablecloth here. You know, you're like my wife. You see the red wine stain. I was kind of like, it's not so bad. And so there is that tendency that we focus on a thing that's different, a thing that sticks out, the kind of the sore thumb. We don't think about the big picture. At least this is my own bias. And these are some cognitive biases, which I think we're aware of some of these. We know about some of these. So I think we all know about anchoring bias, and we may bring that to many aspects of our practice. Again, that red wine stain's a little bit of sort of related to negativity bias. And again, the bad news, you know, travels faster than good news in my experience. This availability heuristic, again, our patients, I think, suffer from that because, again, they heard this on the news last night. Their neighbor told them this yesterday. That's the recent information they had. But I think one that really impacts many physicians, particularly in medicine, I think surgeons, they may not suffer from this at all, but this zero risk bias that we want to have no harm happen to somebody. The fact that we may be doing some good stuff, we tend to ignore that perhaps. And again, we have made this into Latin to justify that bias. So this is, you know, first do no harm. And it's something that I think we throw about quite a lot when we don't want to do something. And it's a bit like our get out of jail free card. You know, you just put that down. Maybe it's like the Uno reversal card, you know, so it's like, ha, and you walk away and say, we'll see you in the consult service. So I think there are some biases, you know, so that often it's about a professional identity. You know, my identity is that I'm an expert. And if somebody's asking me about something that I'm not an expert in, and they're challenging that because they've got data about a new drug that is going to be something for Alzheimer's disease or for Parkinson's disease, that's not my domain. I may well tend to be a bit skeptical about that. So I'll say, well, show it to me, because again, it challenges my professional identity, my existing beliefs, and then just that natural tendency for us all to cling to inertia. You know, we want to stick with what we know, and we really don't like change. And I think what we struggle with is often to think about the context. So this concept came from a lady who lives with diabetes, who has worked to develop do-it-yourself algorithms that connect her pump with her glucose monitor, so they would automate her insulin delivery. So she did this before the companies produced them. And people used to say to her, well, look, that's really risky to do what you're doing. And her answer said, there is some risk with this technology that I built in my kitchen, but you're forgetting that I started with really high risk with these needles and syringes and a drug that could kill me if I give too much or too little. You're thinking about it from the perspective of you being a healthy person who doesn't have diabetes. And so if you think about somebody who's got cardiovascular disease, diabetes, obesity, they have some major risks to their health, short-term and long-term. And with the new medicine, that risk will be reduced. There will be some adverse events and some risks with the new medicine, but there's a net benefit, would be my perspective. If you take a healthy individual perspective, like the CBC reporter who I spoke with last week, you know, their risk is low. The new drug isn't going to reduce their risk because it's so very low. And all they would experience potentially would be adverse effects from the medication. So the net benefit is not in favor of treatment. So what have you seen in the news? So I don't know if you saw this one. This was the U of A's top clicked story for a while. And again, just to let you know, like Jason Dyke is the PI behind this. He's a very, very dear, good friend of mine and a member of the CVRI and the ADI. But you see stories like this, you know, in mice. At least they put the in mice in, but they did throw in the human cells bit as well. But what's confusing is that it's also right next to this other story on the U of A website saying the same drug shows promise to prevent heart failure. You know, so no wonder it's tough to figure out. So this is Jason's study. And again, all you need to know is that there's complex bar charts and some staining here. But the text is there were no changes in systolic ejection fraction or diastolic function on echo. And they've got a really cute mouse echo machine. So you can just imagine what that looks like. But there was a significant reduction in LV mass, overall heart rate, and cardiomyocyte area. So they've got this kind of functional data that's kind of like, well, that looks okay. We've got this in vitro smaller stuff that's not so good. But again, when you're presenting this after all these large trials showing these clinical benefits, you just wonder, is this going to help? Now, of course, I had to dig in a little bit deeper. Like, how did they treat these mice? The bottom line was that they gave the mice a dose that was about 80 times higher. These endpoints were detected after 3 weeks of treatment. And again, that just seems like a really rapid effect. The mice lost a ton of weight. I suspect they were sick as dogs or sick as sick mice. But again, they gave a dose that was given every day. We give it once a week. Per kilo, it was about 70 or 80 times higher. Again, just because you haven't seen enough of me today, this is CBC, the National, I think on Friday last week, because there'd been this story about Ozempic linked to vision loss and diabetes. If you have diabetes and you Google what can happen in diabetes, you read blindness, amputations, and kidney failure, none of which are on my list of things that have happened to my patients. Fear of vision loss is a massive, massive fear for people with diabetes. And you can just imagine if you see that headline, you're on these medicines, it's going to be stress inducing. And again, what did the data show? This is the sort of Kaplan-Meier survival group. So this is ICES data from Toronto, adults over the age of 65 who were started on these medicines compared with people who were not started on these medicines, who were propensity matched. And you can see that the people who did not get the new medicines, their risk for this neovascular age-related macular degeneration. So this is macular degeneration where new vessels form that people then need injections or laser treatment for. And again, you detect this because people have had billing codes for injections or laser treatment. And you can see that the GLP-1s are just going much, much faster. So you look at that and think, isn't that terrible? And, what do you think they presented next? They presented the relative risk. The relative risk is 2. But what is the absolute risk? So you'll see that the affected people are shown in orange, which you can barely see because it was 2 versus 1. Okay, so you've got 998 people who are just fine on these medicines compared with 999 out of 1,000 who are just not. And again, this comes back to this motivation for presenting data or doing studies. I think the other thing I'll just, and again, I see Darren and there's others who can probably either endorse me or say, no, you've got it wrong, Peter. But ICES publishes a lot, and you think it was the only source of data in Canada, but they generally don't have lab data. They've only got people over 65 for prescriptions. So the people who are in their 40s and 50s, we don't know anything about them. Age is the big predictor for this macular degeneration. And then you haven't got A1C in here at all. And so your propensity matching may not be adequate. And so there may very well be residual confounding here. So what about clinical practice before I wax too lyrical? So inpatient use of GLP-1s is an important thing for us to think about. And there's been a lot of discussion about this. And, there's been statements by anesthesiologists who never see awake patients, as far as I can tell, saying what we shouldn't do. But I think my feeling is that if somebody is coming into hospital with an illness, symptoms, a disease with the GLP-1 is exacerbating or causing. So if somebody comes in with nausea and vomiting, stop the medicine. That just seems to be common sense. I think if somebody's in with biliary obstruction, they're in with pancreatitis, stop the medication. If somebody's having surgery where they are going to be not eating, it's GI surgery, there's a risk of ILS, again, that's another situation where they don't need it. If somebody's in with pneumonia, I'd probably keep it going. One of the things I think just to remember is that if you stop it because somebody's in with an intercurrent illness, they may not be able to go right back to the same dose. You may need to retitrate the dose up because that gap will sort of let the body forget about the side effect. And again, that often is not done because it's somebody else's problem, perhaps. But if you're going to continue in the hospital, you're going to need the patient's own supply. So it's not on the hospital formulary. So the patient will have to either bring it in or the family members will have to bring it in. And of course, the other thing you need to check is, well, what day do you normally take it? If you took it on a Sunday and you're admitted on a Monday, don't write it up to start today. Otherwise, they probably will get side effects. If you are thinking about starting GLP-1, and again, in our rapid turnover, treat 'em and street 'em domain that we live in right now, we probably don't have the time to do this, but there will be people who are waiting for long-term care, or they've got, chronic wounds or ulcers that, are inpatient for a long time. We may think about doing this as an inpatient. So surprisingly and delightfully, semaglutide is covered by provincial plans. So Alberta Seniors, AISH, Alberta Works, GLP-1 is on the formulary for diabetes. Okay. And some of the forms are getting more and more specific, and you have to kind of sign when blood to say it's type 2 diabetes. So using it for obesity, again, that may be challenging for public plans. Again, it may also be challenging for private plans as well. You almost certainly will have to fill in at least one form, and that is a tedious thing that we all have to do at times. I think the other thing to do is also think about, well, where is the A1C right now? If the A1C is 10%, throw it in, add it on, they need more help. If, however, their A1C is 7.2%, this medicine may bring their A1C down further. If they're on insulin or they're on a sulfonylurea, this could put them at risk for hypoglycemia. So as you bring one in, maybe there's scope to pull it away. And certainly, I think in clinical practice, a really positive thing is if we have somebody who's on, say, 4 shots a day, a GLP-1 potentially could come in that might mean you could get away with mealtime insulin. So if you just got once daily basal insulin plus a once weekly GLP-1, that's, I think, an outcome that many, many people like for day-to-day life. Normally, these medicines come in pre-filled pens, like an insulin pen. Again, you may not be very familiar with insulin pens or GLP-1 pens, but they're really quite user-friendly, and the needles are tiny. And again, if you're of a certain age, you will need your glasses on to be able to see the needle. They're 4 millimeters long and really very, very fine. So my titration tips are, what the label says is what the label says, and what we do in clinic can be different. So I'll talk about the semaglutide pen because it's the one that I know best, probably. So you dial it up with clicks, so you turn the knob at the end, and on an insulin pen, it would be labeled 0-2-4-6. So you go up to the number of units. These pens are, again, very much the same, but the labels are different. So you go click, 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 all the way around several times, and you get to 0.25 milligrams. And that's supposed to be the starting dose. But each click is an incremental step up. And so you could start with 9 clicks or 5 clicks or 1 click, which would be a much, much, much lower dose. And certainly when I use this in people with diabetes who have gastroparesis, again, I often start with maybe 1 click. And rather than waiting a month to go up to the next dose, I'll go to 2 clicks next week, 3 clicks. Again, they'll hardly notice anything, but they'll get there eventually. And I think that slow, steady rise really avoids side effects. And we've seen that actually in some clinical trials of a product that is probably going to be taken off the market because it wasn't selling. But there's good sort of trial data from that context. Yes, it's not on the label, but it's what all the diabetes clinics are doing. I think education is another important thing. So the very shorthand is avoid large fatty meals. Again, fatty meals tend to cause delayed gastric emptying. If you've been out for a fancy dinner with Dr. Kazam because there's a new candidate coming, you may well go home and you'll be on the sofa thinking, oh, I had too much. and it's just all sitting there. And my wife says, "Oh, too much rich food again?" And I'll be like, "Yes." So that's what happens with a fatty meal. So if you do that on top of Ozempic, you probably will throw up. Dr. Morris's tip, maybe I shouldn't tell you this, he would pop a metoclopramide at that point, and it works as well. But essentially, that education is important, and some of the benefits may be about sort of re-educating people about what foods to eat and how to eat them, and certainly the sense of, if you feel full stop, that is the body's natural signal. And again, for many people with weight problems, that signaling doesn't seem to happen so well. And so this is something just to sort of say, that weird feeling, that's you're triggered to stop eating. This is an AHS resource that's just actually hot off the press, and there's a QR code. But if you search for nutrition and incretins on AHS website, you'll find that without too much difficulty. Surgery, perioperative. So again, I said this already, hold if there's abdominal surgery. People can resume them when the oral intake is adequate again. But if people are not eating, don't add the medicine back in. If people are having sedation or general anesthesia, just be aware that gastric emptying may be an issue. So if somebody's on Pantoloc and metoclopramide and semaglutide, and they're going for a procedure, just think about that. They may want to fast for a little bit longer. You may want to say, can you go on a liquid diet for a few days before? There are some recommendations about doing point of care ultrasound to look for gastric emptying contents. So again, if you want to do that, great. But I think the reality is that these drugs have been on the market for years, and we've not seen this epidemic of aspiration pneumonia. I think the other thing for the GI doctors is that bowel prep, may not be so very good. So again, if people are on these medicines, again, maybe they come off it, maybe they come down a bit. The trouble is that with the once weekly dosing, you probably have to be off it for a long time for any effect to come through. And then there are risks of being off it. So if you stop your medicine 5 weeks before your surgery and your diabetes is not controlled, you come into a hospital and then get cancelled. Or your blood sugars are out of control and you get a wound infection, or the metalware in your hip replacement gets infected. So again, it's that net benefit, net risk thing that we need to think about. And I think the thing which we often forget is that sort of osmotic diuresis that results from hyperglycemia. But that together with hospital where, there's no access to food and water for lots of times, can be a risk factor. And then this question about, okay, that's all very well for the pre-op clinic to say stop your GLP-1, but who's actually going to get them back on it safely and effectively? So to conclude, these are transformative therapies. They have made diabetes practice and obesity practice very, very different. They tackle the diseases, but they have an impact for hard endpoints, but as well as the quality of life things which are important for people in the interim. I think we've got safety and efficacy data from very high quality RCTs. Adverse effects, we may see rare adverse effects in observational data, but we need to be responsible with how we use observational data. And again, our cognitive biases may affect how we assess and apply clinical data. And there is one additional cognitive bias that I learned about in preparing for this, and it's called the G.I. Joe fallacy. And the G.I. Joe fallacy is essentially saying that just because you know that they're cognitive biases that you have isn't adequate to actually fix them. Okay, so awareness is part of the journey. It may not be the whole battle. So with that, I will stop. I hope you have learned a little that is hopefully useful for your practice and possibly your social life as well.
Thanks, Peter. That was fantastic. I think you gave very compelling evidence in terms of diabetes and, especially that graph that you showed. But, one of the questions online and that I have as well is the vast majority of this cognitive bias that, you're seeing, especially in Canada, is related to the obesity population and without diabetes. Being a diabetes doctor, do you have any opinions, or do you want to weigh into that, or would you rather just?
Well, I'm happy to weigh into anything to large extent. I always have an opinion. Hopefully it's one that's helpful. I think there's a massive amount of stigma around obesity. And that is a huge problem. And I think the Canadian Obesity Society and other international groups are really working hard on that, because I think until you tackle the stigma, you're not going to get any action. And actually, diabetes is a little bit the same. Again, diabetes isn't a sexy disease. Nobody wants it. Nobody wants to admit they have it, because again, I think it's also got stigma with it. And that's a major focus for Diabetes Canada over the next few years, is what they're calling change the conversation. Because I think until you sort of say diabetes is a thing, it's not your fault, it's a product of your genes largely, it's going to be then difficult to sort of say, look, let's tackle it seriously, because it is associated with reduced life expectancy and all these comorbidities. But I think what I find kind of frustrating is that, you can get a GLP-1 if you have diabetes, but if you have obesity, that's your fault. And why would we possibly help you? So I think that's really unfair. I mean, I think the other thing that many new medicines, we tend to use an end-stage disease. And, I've been involved with guidelines. They say, well, what's the evidence show? The trials get done in the high-risk population. But if my brother-in-law has got pre-diabetes and a coronary lesion, I'm going to say you should be thinking about a GLP-1, because it could stop you getting diabetes. And certainly tirzepatide, again, really strong data, the risk of progressing to diabetes is 90% lower if you're on tirzepatide. That's, again, you don't have to be a whiz to do the number needed to treat for that one. So I think we've got some challenges. And again, we need to be careful that we're not sort of reinforcing those things. And it is tough, because I think in hospital, you're overwhelmed. You see all the bad things happening with obesity and with diabetes. And it's hard for that not to come out in some degree of blame or judgment. Again, in our better selves and our better moments, we don't do that. But I think we struggle with empathy when we're busy and stressed. And again, I think just taking some time out to sort of say, this could be your sister or your brother, your mum, your aunt, is good advice for all of us.
And there's other conditions as well where it is easier to get fatty liver, you talked about, and of course we see a lot of heart failure, and sort of adding that to that. Adrian,
are you aware of then any provincial moves to take some of the blocks off? I see multiple people with obesity-related complications, and maybe A, can't afford, B, can't get access.
Yeah, I mean, I think the reality is that I'm not aware of any that are effective. I think there are strong voices. There's a great desire for advocacy, but actually, I don't think we've got a destination for those conversations. And I think there's a lot of, it's not even joined up thinking in terms of, we look at the sticker price and say, that's expensive. But again, it's somebody else's budget that's paying for the wound care, the home care, all those other things. And again, that's not unique to this class of medicines. But I think the data is becoming very, very compelling. And I mean, I think unfortunately people will then live longer to get other things. So the next rash will be ozempic reduces this cancer, but increases that cancer in 90-year-olds. So again, that'll be over to you.
Dr. Jaman.
Excellent talk. I really enjoyed it. I was struck by the list of conditions, and when you look at that list, you wonder what has not been thinking. My question is, in your opinion, what is the common thread for all of these somewhat disparate conditions? I mean, I asked the same question to Dan Drucker when he was here.
Well, I suspect his answer is better than mine. These drugs work on G-coupled protein receptors, again, which are widely spread throughout the body. They're involved with signaling, they're involved with metabolism, they're involved with inflammation. And again, I think as we go by, because a lot of the debate in the obesity and the diabetes trials was, what's the mechanism? Is it the A1C reduction that leads to heart disease? Well, we know a ton of drugs reduce A1C that haven't had these endpoints. Is it the weight loss that does it? Well, actually, the benefits seem to accrue before the weight loss has happened. And I think there's increasing interest in those sort of inflammatory processes. Again, I think immune signaling, and I think the links between sort of immunology, metabolism, nutrition, and vascular health, I think that's where it's going to be. So I think the science and the biology is really fascinating. And I think it is important that we do that work because we'll design things which are better, more effective, more targeted, perhaps with less side effects. But we don't need to wait for that to start using these medicines, particularly in those who are at highest risk.
My patients can't often afford ozempic, GLP-1 inhibitors, and I have a subgroup of patients who tell me they're taking berberine as a alternative natural version. They tell me. So then I tried to do some research on this to see is this for real, and it seems like there is some data in favor and some not. What are your thoughts about patients doing that instead?
I think there's a lot of interest in kind of natural compounds, and people are doing it. And again, I think that just talks to kind of like health beliefs, and our medical model and the fact that we can't explain all the things that people experience. So I think, my initial natural reaction is like, well, no, it can't be true. But, there may be some elements of truth. I think what I worry about is that people are being sold things because they've got a desire that maybe aren't going to work. And certainly you may be sold things which have got bad things in that cause adverse effects. So I think I would again try to listen to my patient, what is it you feel that this is doing for you? Are there any side effects? Is there any safety concerns? I mean, very briefly, I did have a patient when I was a trainee who gave himself hepatitis from eating carrots because there was so much vitamin A. He was eating about 5 kilos of carrots a day. So again, natural things can do bad things too. So I think I'd take that kind of approach of like not denying, not arguing about it. Tell me about your beliefs, focusing on saying, well, this is what I know about my expertise. But if you can't afford it, I mean, you've got a problem still. And I don't think it's an easy answer.
I was wondering, sorry if I missed it, could you comment on sub-Q versus oral GLPs?
Yeah, so most GLP-1s have been given sub-Q because, the peptide hormones. There is an oral version of semaglutide branded as Rybelsus. It's got some very interesting sort of pharmacology. It's got this coating. It has to stick to the lining of the stomach. It opens gaps between the gap junctions so that the drug can be absorbed. If you have to take it on an empty stomach with only a tiny amount of water, because if you take a big drop of water, it gets washed through, it won't be absorbed. You need to have breakfast half an hour later, because if you don't, even more drug gets absorbed, you'll get more side effects. It's about 1% that gets absorbed. 99% goes to EPCOR. And there's been a reformulation to increase the bioavailability. So it's a daily medicine that people have to take. It does work. It's, in my view, a little bit fiddlier to take, but it has got hard endpoint data. So the SOUL trial was the big CV outcome trial with the oral version of semaglutide, just published quite recently, and it showed all those same benefits. So it's the drug that does it, and there's nothing magical about how it's given. But again, there'll be places in the world where it's far more preferred. And again, maybe in primary care, it's easier to sell or to sort of persuade people to take a tablet than an injection.
So is there going to be a suppository version for the French?
We've got a final question with Dr. Bello and then.
Thank you very much. So can we have class effect that should have benefit? For example, in reducing renal rate, does it have to be semaglutide or previous?
Yeah, so the question is about, is this a class effect? And I think by and large, it is. Now, there was a drug called albiglutide that did show some benefits, but for CV outcome, but not so much for weight loss. Some of the earlier products, exenatide, lixisenatide, didn't show cardiovascular benefits, but they were used probably at much, much too low of a dose. So I think you can't completely take it for granted, but we're just seeing very, very consistent that, almost all of the products that are being developed currently, which have got sufficient duration of action, sufficient efficacy, are then translating into these long-term outcomes. And the dual agonists, the triagonists are fascinating But we need to be a little bit careful, I think, about this weight loss Olympics. You know, and I want 50% weight loss. You know, if I took those, I would sort of slip down the drain. And I think the other question is just about, you know, how do these fit into chronic disease? So we may need sort of an initiation to achieve a target and then a lower maintenance dose long term. I think if we start them and stop them, we'll exacerbate yo-yoing, which is probably a problem.
So once again, we did promise Dr. Senior is an outstanding speaker, and I think it was a great rounds. Thank you so much for taking on this important topic.